गुड मॉर्निंग एवरीवन। वेलकम टू अनदर सीरीज ऑफ स्टडी पैथोलॉजी विद मी। और आज हम डिस्कस करेंगे बोन। सो बोन इज अ वेरी अंडररेटेड टॉपिक इन पैथोलॉजी एंड इवन व्हेन आई वाज a UG student, I didn't give any importance to this topic, and the concepts were not very clear here, mostly based on the regulation of the bone और कैसे regulate होता है, resorption और absorption और proliferation कैसे होता है। ये concept मेरा बिल्कुल सही नहीं था, that is why I had to go back in residency and read all about it. So I have two references here. One is Robbins, the latest edition, and the next one is Ackerman, which is my book in pathology, PG histopathology, that I'm referring to. So let's get on with the topic. So pehle we have divided this topic into two. First one, we'll discuss the normal bone, the morphology and the regulators of bone, and with a few important benign conditions of the bone. And next we'll go with the WHO classification of bone and cartilaginous tumors, and we'll discuss a very few yet very important topics in the part 2 of this video. So coming to the bone. So bone has a matrix which contains minerals and hydroxyapatite, and the osteoid will also contain collagen type 1. So the cells, mainly there are three types of cells that you have to remember. One is osteoblast, osteocyte and osteoclast. So osteoblast has the function of synthesizing, transporting and assembling the matrix, which is mainly consists of the minerals and osteoid. So when you see an osteoblast, you'll see it's a plasmacytoid morphology. And why does it have a plasmacytoid morphology? Because it has a perinuclear halo, and this perinuclear halo is because of the prominent Golgi zone here. Also, one very important thing that you have to remember is the cytoplasmic alkaline phosphatase content in osteoblast. So alkaline phosphatase is increased very much in the osteoblast, which is important. Next, coming to one of the excellent markers of osteoblastic differentiation. So if you want to see that osteoblast proliferating in a tumor or in any condition, this is one thing that you can give. This is a marker which is SAT-P2, and it's an excellent marker of osteoblastic differentiation. So itna hi theory काफी है osteoblast में. I think this is enough. Coming to the next cell, which is the osteocyte. So osteocyte is usually seen in the lacunae. They are present in the lacunae. Lacunae are khali spaces usually. So they control calcium and phosphate, and they have a very important function which is known as mechanotransduction. So they will detect the mechanical forces, and based on that their biological activity changes. So that is one function. Mechanotransduction is a function of osteocytes. And the last cell is osteoclast, also known as the multinucleated macrophage, that is present in the bone. So where does these osteoclasts lie? So when you see a bone surface, they will usually lie in very close to house-shaped lacunae. So this is known as house-shaped lacunae, and that is where the osteoclasts are usually present. And how are they attached? They are attached by the surface integrins to this bone surface. And ये जो surface integrins है, they will attach here, and this place is also known as resorption pit, because osteoclast causes bone resorption. So where they sit, there will be resorption here, and that is why it's known as resorption pit. And they also secrete matrix metalloproteinases in that resorption pit. So like we studied in osteoblast, which will have increased alkaline phosphatase, you have to remember that osteoclast will have increased levels of tartrate resistant acid phosphatase. So alkaline phosphatase होता है osteoblast में, and acid phosphatase is present in osteoclast. So those were the cells that are present in the bone. Next, coming to the ossification. So there are two major types of ossification. One is endochondral ossification, and the other one is intramembranous. So by the name only you can remember. Endochondral matlab inside the cartilage. So there is one term that you have to remember is enlargement. So enlargement is known as the cartilage mold. So inside the cartilage mold, the chondroblast will form the medullary cavity inside. So when a bone is formed like this is known as endochondral ossification. But when the osteoblast directly ossify the mesenchyme, that is when it is known as intramembranous ossification. So that is two types of ossification. Usually all the long bones will ossify with endochondral ossification, and the flat bones are usually ossified by intramembranous ossification. Coming to the regulation, so this is very important and I have divided almost the 8 hormones in based on their function. So पहला वाला है chondrocyte proliferation. So chondrocyte proliferation is done majorly by growth hormone. Next is Indian hedgehog. Next one is PTH, which is parathyroid hormone related protein, and next one is WNT. So other than chondrocyte proliferation, Indian hedgehog also does differentiation of chondrocytes and proliferations of osteoblast. Followed by WNT also does proliferation along with maturation of the chondrocytes. So these four do chondrocyte proliferation, and then the proliferated chondrocytes will undergo hypertrophy with the help of thyroid hormone, and this chondrocyte will also cause differentiation. The differentiation is done by SOX9, FGF3 and RUNX2. RUNX2 will also cause terminal chondrocyte differentiation and osteoplastic differentiation. So again, this is one very important diagram that you have to remember. So let's identify the cells based on what was studied before. So you know that if you see a plasmacytoid cell with a perinuclear halo in the bone, that is an osteoblast. So this is an osteoblast, and if you see a multinucleated giant cell, that is an osteoclast, and the cell in the middle is an osteoclast precursor. So please remember a very few regulatory receptors and their ligands here, which is very important here. So you remember that the rank ligand is present on the osteoblast, and you will have the rank receptor, which is NFK beta, which is present on the osteoclast precursor. So when both of these bind, that causes activation of osteoclast. We also have another thing which is known as osteoprotegrin. So osteoprotegrin will also bind to rank ligand, okay, to rank, but it will prevent the rank ligand formation. So since this is not formed, what will happen? This will not happen. So there will be, when osteoprotegrin and rank ligand fuse together, there will be inhibition of differentiation of osteoclast. So rank ligand and osteoprotegrin will inhibit osteoclast differentiation, but rank ligand plus rank, which is NFK beta, will activate osteoclast. So this activation of osteoclast is also done by one another receptor, which is macrophage colony stimulating factor. This is also present on the osteoclast precursor, and the binding causes osteoclast activation. Other than that, as we studied in the regulation, WNT plus LRP5 by /6, which is present on the osteoblast, will activate beta catenin, and it will cause osteoprotegrin synthesis. So what have we studied about osteoprotegrin? Osteoprotegrin will inhibit osteoclast, which is exactly what it does. It will inhibit the osteoclast, and so now we know the WNT with beta catenin pathway will inhibit osteoclast, but if you have something that will inhibit the WNT, which is sclerostin, which is produced by osteocytes, it will in turn block OPG synthesis and activate osteoclasts. So this one diagram is very important. Please remember, I tried to make it as simple as possible. So that is it. Now coming to the few benign lesions that are present in the bone. The first one is brown tumor. The brown tumor, the name suggests, I know it's a tumor, but this is a misnomer. So in hyperparathyroidism, please remember, it's hyperparathyroidism, there is bone loss, and it will cause microfracture, secondary hemorrhage, and there will be ingrowth of reparative fibrous tissue. So this is what is referred as brown tumor. And why is it called brown tumor? Because they have hemorrhage and hemosiderin-laden macrophages inside the lesion, right? And when you have multiple factors such as increased bone cell activity, peritrabecular fibrosis, and cystic brown tumor together, that is when this is termed as von Recklinghausen disease of bone, also known as generalized osteitis fibrosa cystica. So please remember, this is not a tumor condition. This is usually seen in hyperparathyroidism cases. So when do you say it's a von Recklinghausen disease of bone? When you will see increased bone cell activity, peritrabecular fibrosis, and cystic bone tumor. Next one is the very famous osteomyelitis. So we'll start Based on the etiological factors, you can classify osteomyelitis into bacterial, tubercular, fungal, and syphilitic. So bacterial में the most common causes, please remember, Staph aureus, and you have other causes such as Pseudomonas, E. coli, Klebsiella, and Salmonella. So Salmonella is usually seen in patients with sickle cell disease, and the bacterial can be further classified based on the inflammatory cells that come into acute, subacute, and chronic. So in acute, you will see acute inflammation, edema, and necrosis. Subacute, you will see more lymphocytes and plasma cells, and in chronic, you will see more fibrosis. But when you see that there are a lot of plasma cells and there is features of osteomyelitis, it is known as plasma cell osteomyelitis. And this cell right here is known as a foamy macrophage. When you see that there are lots of foamy macrophages in a case of osteomyelitis, that is when you term this case as xanthogranulomatous osteomyelitis. Coming to the tubercular etiology, again it is mostly seen in vertebrae, pod, spine, and you will see the characteristic caseating granulomas. You will have a central caseous necrosis surrounded by the epithelioid slipper-shaped cells, and then you will have a collar of lymphocytes around it. Then fungal, you will have actinomycosis, blastomycosis, and histoplasmosis as the causative agents. However, one thing that you have to remember is actinomycosis is usually seen in cases of osteoradionecrosis following that. And syphilis, usually cases with tertiary syphilis have osteomyelitis. So let's discuss a few terms that are very important here. One is Brody's abscess. So when there is a localized osteomyelitis in long bones, two L's, localized in long bones, that is when you term it as Brody's abscess. Then you know that there is sequestrum, involucrum, and cloaca. It's very common, and that is a question that most people ask to define one of these. So sequestrum is a necrotic cortex trapped in the pus in cases of osteomyelitis, and around the sequestrum when you have a periosteal reaction, that is when you say involucrum, and when there is a fenestration in the involucrum, that is when you term it as cloaca. So that's it. So there is sequestrum, which is a necrotic cortex, necrotic bone cortex, and then you have a periosteal reaction to it, which is involucrum, and when you have a fenestration in the involucrum, which is a hole or a gap in the involucrum, that is known as a cloaca. So usually pus drains out from that. Then the last entity that we'll be discussing today is the very famous Paget's disease, also known as osteitis deformans. So there are three phases here. First one is osteolytic, second one is mixed. So you'll have osteolytic and osteoblastic, and then you have the burnt out or osteosclerotic. So as the name suggests, first there is osteolysis. Mostly there will be bone resorption. Then you'll have osteolytic and osteoblastic. So you'll have more proliferation, which is enlarged bone in trabeculae, and finally it will be osteosclerotic. You'll be burnt out, and there will be finally a mosaic pattern. So this is very important. So there is mosaic pattern and jigsaw puzzle-like arrangement of the bone because of the prominent cement lines. And why does this happen? Because the lamellar bone is joined very haphazardly. So in etiology, it is usually said that there is a mutation in SQSTM1, or also known as sequestosome 1, which usually gives rise to P62 protein. And viral etiology, they are hypothesizing that there is viral etiology can be because of paramyxovirus nucleocapsid. So this is all that we'll be discussing today. I hope you understood. So one thing that you have to take away from this class is this. This is very, very important. All this regulation is very important. How osteoclast and osteoblast cause their activation and their inhibition. And again, the main markers: increased alkaline phosphatase is seen in osteoblast and acid phosphatase is seen in osteoclast. So I hope you understood this very small session. Thank you. Bye.